Next speaker is Dr. Gurulingappa A. Patil. Sir is going to speak on nutritional needs in critically ill patients. Sir is Gulbarga. Sir was professor, head of the department, MRMC. At present, Sir is president, ISA Karnataka, and IMA president, Gulbarga. Sir is vast experience as a PG teacher and PG examiner. Sir has more than 10 publications. Sir's area of interest is ICU and pain management. Sir is also a member of Rotary Club. Thank you, sir, and welcome you, sir.
Thank you for a nice introduction. On the outset, I have to thank the Mysore team because this conference is going under me only. Thanks for the Mysore ISA organizing team for this opportunity for me to give a lecture. Thank you. Introduction first. Why nutrition is important in critically ill patients? Critically ill patients develop malnutrition quickly, and also catabolic state, the stress will be present, leads to systemic inflammatory response. Patients develops complications such as infection, morbidity, mortality, and multi-organ failures, and prolonged hospital stay. Adequate nutrition interventions has shown attenuate metabolic response to stress and favorably moderate immune response. So the nutrition support in critically ill patient is must, because for the metabolic deterioration has to be stopped, loss of lean body mass, decrease in length of the hospital stay, and morbidity rate. Coming to the malnutrition, can be defined as a state resulting from the lack of intake of and uptake of the nutrition that leads to altered body composition, decreased fat and muscle mass, leading to a diminished physical and mental functions, and impaired clinical outcome. Now, a practical approach towards the nutrition, how you should practically approach when a malnourished patient in critical patient. So first we have to assess nutrition status in scoring system, calculate nutrition requirements, goals of nutrition support, when to start and when to end, and which route should we use, whether enteral, parenteral, or the other, which and especially precautions has to be taken in the diseased states like trauma, injury patient, brain injury patient, and cardiac disease and chronic renal failure. How to assess a nutrition status in this? It is very much difficult, but however it may be summarized as ABCD, as you show, as the table is shown. Anthropometric measurements, biochemical tools, clinical assessment, and dietary assessments. In anthropometric measurements, body weight, skin fold thickness, head circumference, and also head-chest ratio, and BMI. Biochemical tools, hemoglobin, albumin measurements, transferrin, and pre-albumin is very much important, and lymphocyte count. In clinical assessment, we can take nutritional history of the patient, general physical examination, loss of subcutaneous fat, and edema and ascites. Dietary assessment of the past 24 hours is very much important to take in history to assess the nutrition status. By coming to scoring system, must and nutrition risk screening, NRS 202 guidelines, and nutrition risk in critically ill score, that is NUTRIC score, and also subjective global assessment are the three types of scoring systems are available. And in India, we use subjective global assessment. And for the must, BMI and weight loss and acute disease effect scores are taken into consideration. And in the NUTRIC score, comorbidities and clinical conditions are taken into consideration. In India, SGA, that subjective global assessment is mainly used. And subjective global assessment in Indian patients is, why it is used is inexpensive and quick bedside tool. So the parameters which have been taken for the scoring system in this is weight loss, dietary intake, gastrointestinal symptoms, nutritional functional status, and muscle wasting, fat scores. 1 to 2 score is a severe nutritional malnourished, and 3 to 5 is moderate, and 6 to 7 mild score. Now coming to the nutritional requirements, how we have to calculate. by Harris-Benedict equation, it has been calculated for men 66 plus 13.7 into weight plus 5 into height and minus 6.7 into kg, and for women it is 9.6. So we can by resting energy expenditure can also be calculated, that is BE is into 1.2. Coming to the next, daily nutritional requirements, how we calculate, and European nutritional guidelines, that is parental and enteral nutrition, European Society of Parental and Enteral Nutrition Practice Guidelines, they calculate the nutrition as per that. Total is 25 to 35 kilocalories per kg per day, and proteins 1 to 2.5 grams has to be involved per kg per day, and rest is 60% carbohydrate and 40% lipids. And in addition, the micronutrients are very important, and we have to keep the positive nitrogen balance in this. Goals of nutrition support include prevent and treat micro and micronutrients deficiencies, attenuate the adverse effects of the metabolic response to injury, prevent the cascades of leading to the sepsis, improve nitrogen deficit, prescribe dose of nutrition as per the existing metabolic conditions, preferably via enteral or route, find compatible route of nutrition, avoid complications related to technique of the dietary delivery, improve patient's outcome. Now, when to start the nutrition? The time initiating nutrition support is a complex issue involving various factors which include pre-illness nutritional status, type, severity of the stage of critical illness, and organ failures have to be taken into consideration, route of feeding, and use of special diets. In general, early feeding is the priority has to be given within 24 to 40 years or after the injury, acute onset of the injury. We have to start the nutrition. Conventional feeding, it is after the 3 days we have to initiate, and late feeding refers to the nutrition after 10 days. Routes of nutrition. Nutrition support can be given through one of the 3 routes, that is oral, enteral, and parenteral. It is important to know that the patient is receiving adequate nutrition. Oral route is if the patient can eat, he has to be encouraged. And enteral route, when oral intake has been inadequate for 1 to 3 days and composition ready, it is advantageous, ready to use, and osmolality has to be kept between 200 to 480 millimosmoles, and mainly carbohydrate composition, that is polymers of monosaccharide, has to be there. In parenteral nutrition, the entire enteral route is contraindicated. Nutrition needs for longer period, and composition and the osmolality has to be maintained 700 to 1200 milliosmoles per liter, and carbohydrate composition is the must. Enteral route. Coming to the enteral route. Enteral nutrition is preferably over parenteral as early nutrition in critical ill patients. Advantages of enteral routes are improves mucosal blood flow, prevents intramucosal acidosis, prevents permeability disturbances, and eliminates needs of stress ulcers, and also prevents bacterial translocation from the gut. Contraindications: circulatory shock, intestinal ischemia, complete bowel obstruction, and pancreatitis are the contraindicated for enteral route. Methods, that is, we can nasogastric tube is the most commonly preferred, and nasojejunostomy, nasoduodenostomy, and percutaneous feeding tube and jejunostomy tube can also be considered. Tube feeding practice guidelines. Nasogastric tube feed is the routine method for enteral route, first choice of enteral route, and continuous formula feeding with pumps and gravity bags can be preferred. And long-term enteral tube feeding associates with development of Clostridium colitis, so it can be prevented by systemic formula feeds, and also should be preferred over the blenderized feeds and antibiotics. Enteral feeding formula can be standardized, pre-digested, disease-specific, blenderized, and additives. Additives for glutamine, dietary fiber, and branched chain amino acids have their own advantages. How to give enteral nutrition? Confirming the tube position, that is clinically or radiologically, upright position, that is 30 degree, upright position, monitoring the tolerance and adequacy by, actually the normal residual gastric volume is 300 to 500 ml. Ensure that the gastric residual volume should be less than 200 ml before giving enteral feeding. If more than 500 ml RGV, then the enteral feed can be continued with less volume, which is measured by syringe aspiration or ultrasonography every 8 to 12 hours. Avoid bolus feeding. Large volume of feed in the stomach will increase the risk of aspiration, and use prokinetics like metacolor movement. Parenteral nutrition. Total parenteral nutrition is an absolute indication of parenteral nutrition is gastrointestinal failure. Route of infusion is peripheral or central. The peripheral is PICC lines, peripheral lines, that is we can puncture the basilic vein and it ends in the brachial vein. And for less than 4 weeks, the peripheral lines should be used or preferred. Disadvantages are phlebitis can only give low concentration or low osmolality solutions. So central parenteral nutrition is through CVP, central vein line, is preferred. Catheters, catheter end will be placed at the just above the right atrium. For longer duration like months, we can use this central nutrition, and high concentration can be given in this route. General rules of the TPN. It should be sterile, has to be maintained under 4 degrees Celsius. No medication should be given during TPN, and daily weight input and output monitoring should be done, and TPN set changed every 24 hours. One is the filter, that is for protein we have to keep it a 0.22 micron filters, and for lipid that is because they are 5 times, the molecules of lipid are 5 times bigger than the proteins, so you have to keep the filters 1.2 microns. Intravenous nutrient solutions include carbohydrates in 5%, 10% they are available, and 50% and proteins can be given as an amino acid solution and contain 50% essential and semi-essential amino acids. Lipids, lipid emulsions 10 to 20% in strength are available. Electrolytes and micronutrients have to be supplemented in the intravenous nutrition solutions. Trace elements like copper, chromium, selenium and cobalt, zinc has to be the part of the intravenous nutrition solutions. Termination of parenteral nutrition goal. The goal is to restore the oral or enteral feeding as soon as possible when the gastrointestinal functions improves. Gradual transition from parenteral nutrition to oral or enteral nutrition has to be done. Reduce infusion rate up to 50% of 1 to 2 hours before stopping the parenteral nutrition. When 60% of the total energy or the proteins requirements are taken orally or enterally, then the patient can be switched to stopped parenteral nutrition. Complication of total parenteral nutrition. Short term and long term. Electrolyte imbalance, hypo and hyperglycemia, lipid emulsions related to allergic reactions, volume overload in congestive cardiac failure, catheter related like pneumothorax, hemothorax, chylothorax and cardiac tamponades and sepsis. Long term metabolic bone diseases, gallbladder or lithiasis, hepatic dysfunctions are the main complications of total parenteral nutrition. Monitoring of patients. During enteral or parenteral nutrition, we have to monitor all the vital signs like and fluid balances, delivery of the equipment on the pumps, and during first week of measurement of electrolytes, and for the first day measure the blood sugar level every 6 hours for 24 hours, and we have to keep a positive nitrogen balance. This is the chart which has been given, and we have to go according to this in an ICU patient. And references, these are the references which I have gone through for this presentation, and just thank you for the